This is an atypical episode. This is actually a composite episode of all the different short form videos that I've made in the Occupational Science Alphabet series that are focused on the occupational constructs of occupational apartheid, the one that we're using to begin our series. I'm actually looking at probably skipping to letter O in our next letter because occupational, knowing the nuances of that formal definition and how that shifts based on cultural context is quite essential to understanding almost every other construct in the series. But I went ahead and edited all the clips together for those who want to engage in the series with a deep dive, one letter at a time. I don't want to leave you guys out that tend to consume more long form content here on the Substack or on YouTube. But I would love for you to follow along and engage in dialogue as we go. I am posting these short form videos on TikTok, Instagram, Facebook, and LinkedIn for as long as I can sustain that, and would love to have your commentary. I'm also looking at starting a free school community for those of us who want to do a little bit more interactive activity. I'm looking to start a journal and book club so that we can get to know each other better and really support each other in getting to know occupational science a little bit better, applying them more to our own lives. In addition to the deep dives that we took in the short form clips, I really encourage you to take a look at the supplementary resources recommendations to take in an article on occupational consciousness by Dr. Alwani Ramagundo, in addition to Frank Cronenberg's dissertation, which are both freely available online for those who want to learn more. Thank you again so much for following and humoring a bit of an atypical episode. I'll put these together on the Substack after I've completed the full letter so that we have a comprehensive resource that can be freely available across borders to help with knowledge translation. And I'll put together a library of these clips as well within the free school community. So I hope you stay tuned and consider joining that, and look forward to more letters and more episodes with you this year in 2026. Thank you.
If you're an occupational therapist practicing in the United States, chances are you're already using occupational science. You just may not know the words exactly how to contextualize it in everyday life in traditional US practice. My name is Dr. Josie Jarvis. I am an applied occupational science educator and clinician in the United States practice settings for the past 10 years, traditional settings, and I specialize in helping to simplify occupational science so that occupational therapy can finally be known for its unique and distinct foundation, and we can be better understood both within our own practice and within the general public. And that's why I'm creating the Occupational Science Alphabet series. And this week we're starting with A for Occupational Apartheid. In the 2017 Dictionary of Occupational Science and Occupational Therapy, edited by Dr. Molyneux, the formal definition of occupational apartheid is the exclusion of people from opportunities for occupational performance and occupational engagement by society and its systems due to political affiliation, socioeconomic status, ethnicity, health status, and a range of other characteristics. The word occupational apartheid can carry a lot of weight and heaviness in regard to our historic context and contemporary social justice challenges. It's actually a construct that shows up very presently throughout most traditional US-based occupational therapy treatment contexts. Looking through the lens of occupational apartheid invites occupational therapists and occupational therapy assistants and the general public through the lens of occupational science invites us to do is to see disabling aspects of an environment that transcend the individual. So in traditional occupational therapy that is more clinically grounded, we're often looking for participation and performance challenges that are endemic to an individual person in relationship to any given health pathology, developmental difference. We're looking at the level of the individual on itself and finding a source of dysfunction or limited access and participation within the context of that individual, and basically shutting out any regard to context outside that individual, which if you practice in the US, you're probably already not doing this. We are taking into account also features in the environment that can be contributing to a particular occupation not being accessible, not being engageable, or not being like motivating and stimulating for our clients. This is the secret of occupation, is it always transcends the individual, even though it includes the individual intrinsic motivation and volition capacity and allows space for the unique differences of how individuals engage in occupational differently. Occupational apartheid allows us to make explicit and visible where features of the social environment are playing an equitable role in limiting performance and participation. For example, in traditional settings, it could be somebody who has invested in long-term care insurance that happens to cover a mechanical stair lift in their home. And that individual will be living in relationship to policies and procedures that enable their access and participation based on their enrollment in a social program. Another individual who hasn't had access to the same insurance-based opportunities may be denied access to a stair lift or not be able to financially access it due to possibly working in a job context where there's been patterns of wage exploitation or the systematic denial of health insurance. And so the access and participation barrier isn't just rooted in the individual being unable to walk up the stairs on their own. It's also tied to policies and procedures that make access participation not really accessible. And as such, as occupational therapist, to address impairments of occupational apartheid, that can expand to our role in being involved in policy and advocacy to help mediate how insurance policies are working, or to draft letters of advocacy, to even support our clients learning how to create something like a GoFundMe account to overcome these barriers. Because just acknowledging the existence of these social barriers helps empower in generating problem solving and solutions similar to our founders in the arts and crafts movement. One of the common ways in which occupational apartheid is really built into traditional US-based practice is actually through school-based practice. Inclusive education across the United States has developed under this foundation that we're helping students perform and participate in the least restrictive learning environment. So often, occupational therapists are helping to wield tools such as an individualized educational program on a collaborative team to adjust and accommodate environmental barriers that can allow openness for access and participating and integrating with peers. This is where occupational therapy mediates through policy and not always through intervening on the individual to mediate increased inclusion, participation that is, according to AOTA's Vision 2030 and 2025, inclusive and accessible to all. Another way that occupational apartheid can affect traditional practice in the United States practice settings can be variations in how different scopes of practice are interpreting what OTPs can and cannot do, and what our regional work settings are making possible for us with the utilization of resources or access to spaces. So when we show up at work to advocate for full scope occupational therapy, for the required equipment to perform our jobs in a way that is equitable with other rehab clinicians, and even just advocating for our own equitable compensation, those are ways in which we could use the lens of occupational apartheid to mediate through access barriers to policies to find tangible solutions. Rather than intervening clinically on an individual level within the individual body system, occupational apartheid empowers and expands us to build collaborations and to mediate problem solving by also intervening in the environment and building collaborative problem solving within our social context to mediate policy. Normally in the United States, I've noticed that policy can be something that is viewed as fixed and as a barrier and not something that's amenable to overcoming. But this is something that if we really connect to occupational therapy's roots and empowered by the lens that occupational science offers us, we can actually make really powerful progress in supporting our clients and ourselves. Some ways that you can start incorporating occupational apartheid into your contemporary practice can be supported by these reflective prompts. Is this a participation barrier rooted in an impairment, or is this a sustained environmental restriction? Where in my caseload are structural policies limiting access to meaningful occupation? Am I documenting systemic barriers clearly or defaulting to individual deficit language alone? How might funding caps, transportation access, insurance limitations, and school policies shape occupational opportunity, and for who? And what would advocacy look like in this case, even in small ways, can be powerful. Occupational therapy has always restored participation. Occupational science helps us name when participation is restricted by systems, not bodies. And you can learn more about this on my capstone website, engage.evolveliving.network.com, and on my Substack, josiejarvisot.substack.com. Thank you so much. If you want to learn more about occupational apartheid specifically, I highly recommend picking up a copy of Occupational Therapy Without Borders, edited by Frank Cronenberg and Nick Pollard, and just even typing occupational apartheid into Google Scholar and seeing a diversity of different perspectives on this very expansive and important, unique construct to occupational therapy practice, not just in the United States, but also worldwide. This can really empower your practice and help give you terminology to distinguish your contributions on the team wherever you practice, and our distinct role in evolving and shifting the landscape, not just within bodies, but also in the systems that surround them, and taking an approach to see how we can open up more possibilities, enable engagement, participation, performance, and ultimately occupational justice and liberation, all constructs that are currently embraced by the Occupational Therapy Practice Framework, fourth edition, and AOTA Vision 2030. Hello, if you are a US-based OTP, you are probably already applying occupational science in your practice. You just might not know exactly the words to contextualize it with, and that's why I'm here. My name is Josie. I am an occupational therapist in the United States. I currently practice in home health, but over the past decade, I've worked in a variety of different traditional US-based practice settings, including school-based practice, outpatient pediatrics, acute care hospitals, including specialized post-acute same-day surgical care, in addition to memory care. It goes on and on, because a lot of us know OTs are a lifespan profession from birth to earth, so they say, and we help support through transitions throughout everyday life. And having a distinct profession that exists in those liminal spaces of transition actually requires a distinct science base. Oftentimes in our traditional medical model, that appeals to what's called like more reductive or deductive based inquiry. That's where we look at removing context for a situation, isolating specific variables, and trying to understand what can be stable about that phenomena over time. In contrast, occupational science blends mixed medium approaches to inquiry, so including qualitative domains of inquiry, integrating that with more objective deductive, because really in everyday life, everything is actually quite blended together, and that can be where the challenges emerge. And so from that, we need to utilize a distinct lens and distinct process of inquiry and asking questions, which is very scientific. And even though it includes the qualitative, that actually enhances its specificity, its complexity, and its impact when leveraged therapeutically. So right now I am doing a Occupational Science 101 alphabet series with focusing this week on occupational apartheid as A. So occupational apartheid is one of those constructs that was developed primarily by Frank Cronenberg, who practices based out of South Africa. And his partner, Dr. Elwani Ramagundo, they're very heavy hitter, powerful theorists in occupational inquiry. I will say that I don't believe that Dr. Frank Cronenberg particularly identifies with the lens and umbrella of occupational science, but it is the study of occupation, and so everything falls under that umbrella. I shared another video. I'm trying out different ways of creating content about kind of the basic definition of occupational apartheid, which is basically when there are barriers to participation, performance, and engagement with occupation that are sourced in how social systems are organized, and the various different isms that can impact access to care, performance, and the ability to participate meaningfully in everyday life. Knowing that this is a construct innovated by Dr. Cronenberg and the themes that emerge from both his and Dr. Ramagundo's work, big focal point of their work is collective liberation and ecological balance. This can be somewhat of a controversial construct at times within the occupational therapy context within the United States that sometimes has timidity and apprehension around social justice work. However, what's important to be aware of is that social justice work and ecological approaches to addressing access disparities and reforming systems is actually the soil from which occupational therapy has always grown from and developed with in the context of disability justice movements in particular. And given our origins in the moral treatment movement and arts and crafts movement, a lot of that came from the mental health and looking at how do we enact not just scientifically sound health practice things, but also how do we practically implement moral reasoning in our day-to-day practice. And I know that this is something that is very concerning to most of the clinicians that I work with on a day-to-day basis. Whether you're practicing in skilled nursing, where maybe discharge decisions are being made because of inequities between different types of insurers or Medicaid Advantage plans. Just got word about a new federal proclamation on the systems level to deny durable medical equipment throughout the U.S., whether it's by those that provision durable medical equipment being unable to enroll for expanding services to perhaps underserved areas, or as we see commonly, denial of appropriate equipment that often affects us as OTs. We tend to utilize equipment a lot more often than other rehab providers, and you've probably noticed that maybe equipment for self-feeding or adaptive dressing equipment might not be provided by your clinic and things like that. Those are examples of occupational apartheid, barriers being implemented and posing barriers to access and participation, both for you as an occupational therapy provider, but also impacting the performance outcomes for your clients. Now, why it's important to understand this type of terminology and to get orientation to the different lenses of analysis that are offered by occupational science is they help expand what can be regarded as the distinct skill set of occupational therapists when we internalize and enact these in clinical practice treatment settings. What this can look like practically is referencing when policy barriers and environmental constraints are contributing to the limited participation of your client. And this could be as simple as having segregated dining for those diagnosed with dementia from a more kind of general ed senior living environment. Often that's where even traditional geriatric post-acute care is intervening on. We're helping to adapt the task and activity and the environment and the understanding of the care staff, what sort of supports could put in place for residents to access the services that they're often paying quite significantly for. I had the other day was working on an automatic wheelchair to see how we could get it to go under the table so the client could access her food and participate in dining, and had one of the care staff say that she wasn't open to seeing if they could get an accommodation of an additional tray to prevent spillage. And so we met and talked about working with the facility kitchen staff about creating accessible dining for people with disabilities, leveraging things like ADA. So even in the US, very traditional home health intervention, that's working with the construct of occupational apartheid, where I wasn't just intervening and addressing an access barrier within my client. I was also utilizing my skill set and my skill lens to adapt the environment, the policies, and awareness, and building coalitions. And right now, as therapists, we can all play a powerful role with our skilled expertise to comment on the functional impact on the collective of denying durable medical equipment. Durable medical equipment, if that is limited, restricted from insurance coverage, that's going to cause hospital beds to not be able to be cleared as easily because you have to get the appropriate and prompt durable medical equipment for people to be mobilized, even in a adaptive context, to keep hospital beds open for new and emerging things. So that's a case example of how occupational apartheid is creating real world practical barriers that OTs can be an powerful part of addressing. Another example is right now there is a bill presented in Washington state to basically eliminate occupational therapy, physical therapy, and speech therapy from our state Medicaid budget for adults. And this is a way in which occupational therapy and our clients' access and participation in society is being impacted by social legislation that's looking at socioeconomic status as a reason to discriminate for access to these services. And so now it's not about intervening to address this on the individual level. It's not going to be effective in addressing legislation. I'm celebrating the Washington Occupational Therapy Association putting a blast out to all members to sign in opposition to this bill and communicate. And not only did I reach out to try to integrate, I also integrated with the AOTA on this. They put together a blast as well so we could have a broader coalition response. And I've been sending this petition also to other disability and self-advocates I work with, the Nothing About Us Without Us. Our efforts are made more impactful when we use our skill set to create possibilities, not just one individual at a time, but in building effective interventions that can work to mediate how these access barriers emerge in systems. That's in true keeping and integrity with the legacy of the arts and crafts movement, the moral treatment movement, and is alive every day in every setting that we work in, no matter where we're at. And there's this beautiful ripple effect as we create new possibilities for people across the lifespan, knowing that being differently abled is something that we all inhabit at different states in time. And even advocating for ourselves as clinicians can create a powerful ripple effect throughout generations. So I hope that occupational apartheid is something that you consider incorporating into your lens and celebrate it as part of your distinct skill and invitation as an OTP. If you want to learn more about this lens of practice, I highly recommend picking up a copy of Occupational Therapy Without Borders series edited by Nick Pollard and Frank Cronenberg in its first editions. And also just type occupational apartheid into Google Scholar and see what emerges, that you can get more exposed to your distinct science base and empower yourself to think beyond the constraints of the traditional medical model. Celebrate that as your skill, especially in value-based purchasing contexts. This is something that is very distinctive that we can use, and when we use our own words, it allows us to define our own identity instead of letting oppressive systems define us for ourselves based on those limitations. We can empower ourselves just like we empower our clients every day. And occupational apartheid is one of those lenses that can help you find more liberation in your practice. Thank you so much. If you're an occupational therapy professional, chances are you've already been implementing the insights of occupational science in your practice. You just might not know exactly the words to contextualize them yet. And that's what I'm here for. My name's Dr. Josie Jarvis. I am an applied occupational science educator, and I'm here as part of my iteration of the Occupational Science Alphabet series. This week, we've been talking about occupational apartheid, which has been gifted to us in collaboration between Dr. Frank Cronenberg and Dr. Nick Pollard since their 2005 issue of Occupational Therapies Without Borders, which I highly recommend the series for anybody wanting to get a little bit more exposure, especially entry-level exposure to critical occupational therapy that is informed by critical theories and philosophies. I'm going to go ahead and call this part 2 of the series. I got a chance to connect with Frank since publishing my first video and really take into account some ways in which the ways that I've been oriented to occupational apartheid not being exactly accurate to the depth of this construct. If you've graduated from occupational therapy program within the last couple of years, odds are you might have come across this terminology in contexts like Willard and Spackman. You can see here that Willard and Spackman defines occupational apartheid as separation between those who have meaningful, useful occupations and those who have been deprived of, insulated from, and otherwise constrained from daily life occupations. In my previous video, we got to go over the definition in the 2017 Oxford Dictionary of Occupational Therapy and Occupational Science. This definition, paraphrased by Molyneux, says the exclusion of people from opportunities for occupational performance and occupational engagement by society and its systems due to political affiliation, socioeconomic status, ethnicity, health status, and a range of other characteristics. Now I want to take a moment and compare and contrast these definitions that we just went through from one that is straight from the primary source. I'm going to include a link to the primary source of this document in the text. This is Frank Kronberg's postdoctoral dissertation that was published in 2018 and is ongoingly updated with relevant citations. I went ahead and include the definitions for occupational consciousness and collective occupations because they're quite essential to actually understanding how occupational apartheid can contribute to a transformative and liberatory occupational therapy practice, both in the United States and beyond and across borders. Now, the way that Frank defines occupational apartheid directly as somebody with lived experience raising a family in the context of South Africa and living with his partner, Elwani Ramagundo, also doctor, that are theorists that developed and grounded their occupational scholarship contributions from the South African context. So not only are they scholarly informed with diversity of theoretical orientations to occupational therapy practice and occupational science, Elwani's contributed quite a bit to occupational science specifically, but they also have lived experience of growing up and navigating the terrain of pre-apartheid South Africa, and that can really help us appreciate, understand the context around how these constructs emerge, and that helps us mindfully engage with them and apply them in our own clinical practice. So we can see that Frank has defined occupational apartheid as systematically enacted negations of humanity to divide and subjugate collectives of people to the benefit of some at the expense of others. This is done through oftentimes intersecting oppressive social mechanisms, i.e. racism, classism, sexism, homophobia, xenophobia, ableism, neoliberal individualism, masterminding unequal access to resources that can sustain dignified living for all. Now, I'm hoping you may be as shocked as I am to see how divorced the definitions that have been provided for us in Western textbooks are from the original source. And I actually just saw Dr. Kalia Robinson make a post about how important it is to do primary source resources and to make friends with others that can help us access these documents within institutional privileges, which in and of itself is an example of how occupational apartheid can have an effect on us across borders, even those of us outside of South Africa. In my last short form videos illustrating how occupational apartheid is related to clinical practice contexts, particularly where I practice in the United States, I made allusions to how occupational apartheid invites us to utilize a lens beyond the individual and see how environmental barriers can inform participation and performance of occupations that are separate from that clinical picture of just looking at dysfunctional aspects of disabling experiences on the individual level. And that is true, and that is part of how occupational apartheid invites occupational therapy practitioners or those engaging in occupational scholarship or just existing as an occupational being. That framing is very much in line with a continuation of scholarship around the constructs of occupational justice, which have emerged from Australia and Canada. However, being that occupational apartheid is distinctly tied to a decolonial lineage of scholarship, there are several nuances that are really important to get this construct. I'm currently halfway through the manuscript that I'll include in the link below that I hope you might consider engaging with as well. And also include a link to an open access article on occupational consciousness, which is, I believe, deeply inseparable from being able to operationalize the lens that occupational apartheid offers us as clinicians. What I've taken from this body of work so far is an invitation to reconnect to the deep roots of occupational therapy in relationship to this idea of moral treatment and humanization of those who are marginalized. and doing so in a fashion that can allow accountability to the human collective without separating ourselves and our practices from the historic and political context that has shaped international relations, all the way down from the macro and international level to the micro everyday interactions that end up becoming what weaves together the maintenance of these systems even after the policies may have been formally disbanded. Now, while apartheid has been formally ended based on political frameworks, what Dr. Ramagundo and Dr. Kronberg make very clear through their scholarship, especially looking through the lens of narrative inquiry, is that the day-to-day living patterns of coloniality are often preserved in allegiance to the influence of hegemony. Hegemony becomes this individual architecture of hierarchical cultural living systems where body, mind, and spirit get deconditioned and disconnected from context, particularly from indigeneity, and programmed through our habits, routines, and rituals to preserve forms of relationality that we know to be deeply harmful. This connects to the legacy of racism, voter suppression, segregation in the United States, and unequal living arrangements, zoning, and voting policies. Much of this is playing out live on the mainstream news here in the United States. When we look at the trauma that is being cultivated by ICE raids, the systematic denial of human and civil liberties, inequitable treatment in healthcare and educational systems. Occupational consciousness and occupational apartheid invite us to make visible these relational realities where we can acknowledge that in the socio-political context of both the United States and internationally, human rights are not taken as a given for all. And there's a worthwhile effort of grounding our ambitions as a therapeutic profession and as humans seeking to heal from these systems after surviving them, even as we abolish them. There remains consciousness that needs to be rewilded, repatterned, and that can happen in an optimistic way through how we engage in occupation. Through occupational apartheid and occupational conscious, both Frank Cronenberg and Ellie Ramagundo invite us to actively and constantly reflect in our own consciousness and in our relationality. By what ends am I occupied, and how have the systems in the past continue to shape the current occupations that could be causing harm? And what, as an OT, do I want to do about that? Continue for. Welcome to my OS Alphabet series. For this, since yesterday, I got to make sure that I was sharing a really proper definition of this term, which you can see here. This includes systematically enacted negations of humanity to divide and subjugate collectives of people to the benefit of some at the expense of others. This is done through oftentimes intersecting oppressive social mechanisms, i.e. racism, classism, sexism, homophobia, xenophobia, ableism, neoliberal individualism, and masterminding unequal access to resources that can sustain dignified living for all. In the last video, we talk about how occupational consciousness combined with occupational apartheid add this lens in relation to occupation where we're invited to acknowledge the socio-political context that has given rise to the infrastructure around occupational therapy. And we're challenged to critically engage with the role that occupation plays and how we perpetuate the ways that unequal social structures impact our day-to-day thoughts, habits, ways of being, and ways of relating to each other. Combined with occupational consciousness, engaging with occupational apartheid invites us to critically consume everyday actions that perpetuate systems and inequality. And as occupational therapists, this invites us to utilize this lens of occupation to ally with our clients and ally with ourselves to start undoing some of these patterns that perpetuate these systems of inequality. One of the ways that I prepared to understand occupational apartheid a little better for this series is I watched the movie Don't Let's Go to the Dogs Tonight, which is a memoir of somebody who grew up from a young child in apartheid, South Africa. At the time that they were living there, the land was called Rhodesia. However, it was later, through decolonial efforts, renamed to Zimbabwe when there was land restructuring. That this perspective of this memoir talks about how her farm was eventually reallocated in land distribution, and talking a little bit about the social dynamics of how she was raised in the context of apartheid South Africa. For anybody that's curious, I definitely recommend reading the primary sources on occupational apartheid, occupational consciousness, and possibly gaining some narrative engagement with from direct perspectives of those who have lived through pre-apartheid, post-apartheid South Africa, to understand some of the historic and socio-political contexts that gave rise to these concepts and why they might be important. What this movie really helped me appreciate is the nuances of how patterns of inequality get occupationally woven into the realities of everyday living. They did a fantastic job of role modeling how parents relate to race and policy infrastructures have a direct impact on the rules, rituals, and routines that children tend to inherit. It also illustrates some of the hopefulness that we have from being exposed to diverse perspectives and ways of life, and making very human how we can automatically and subconsciously end up reproducing inequitable social relations just merely by not making them conscious and going beyond making stances in alignment with values. With occupational consciousness and occupational apartheid, we're invited to critically break down, reflect, and see how we can utilize the empowerment of occupation to start transforming our everyday lives to produce affirmations of humanity, both for ourselves and others, and seeing ourselves part of a collective human family tree that is seeking to find everyday living patterns that end up cultivating a context of liberation for all. This is very much in alignment with AOTA's Vision 2030. I wanted to share that so far, while engaging deeper with these concepts that are informed by a scientific understanding of occupation, and in this context informed by narrative inquiry and decolonial scholarship, an important part of this series is I want to give you practical examples on how to operationalize these concepts in traditional U.S. practice settings. Here is an example you can see from 2023. I had an opportunity to share a platform with Dr. Susan Yebra and Andy Brown. Susan Yebra is an occupational therapist that practices in New England. I believe she's in Connecticut currently, or Maine, but she has a pelvic floor occupational therapy practice. Andy Brown works in community, at the time, worked in the community occupational therapy for foster children that happen to be experiencing social marginalization due to having queer and gender expansive identities. Here you can see a practical example of three of us as clinicians from across the United States engaging with ways that our social systems and policies were starting to impact the quality of client care and our ability to gather in assembly with our interprofessional peers by bringing visibility to occupational justice and safety concerns with hosting our national conference in Florida at a time when there were severe state sanctions around the Don't Say Gay campaign that was leading to restricted speech, vulnerability to violence and harm, and social sanctions based on who was enabled to freely access toileting, not because of a structural or body challenge or difference, but merely because of the social attitudes and equitable distribution of occupational opportunities to engage, in this case, with our annual conference proceedings. One of the impacts of this conference being hosted in Florida at the time in 2023 was that presentations that might have covered pelvic health or gender affirming healthcare weren't really safe to be hosted at this venue. So a way that this podcast illustrates exercising occupational consciousness and empowerment is us working together to cultivate a platform that could be safe for our gender expansive voices and bringing visibility to the importance of equity and pelvic health occupational therapy advocacy, while also expanding the lens of what barriers to IDL performance can happen that may have nothing to do with medical or mental health or clinical pathology, but rather a commitment to healthy lifestyles and access and participation in community living, as well as educational environments, which hopefully you can see how that connects to school-based practice and our positioning as occupational therapists to also advocate for equity in terms of who is accessing school-based services and making sure that there aren't biases built on gender, color, ableism around our criteria for who gets to access occupational therapy services. Another way that occupational consciousness and occupational apartheid can have a direct connection to everyday practice considerations for US-based OTPs in traditional settings is taking into account how labor conditions such as wage differentials between assistants and therapists, between therapists of color, therapists who are Caucasian, therapists who are immigrating internationally, and how that can translate in pay disparities, ways that us as therapists get treated by our employers, and aspects of productivity pressure impacting our own quality of life and thus challenging quality of care for our client. Just by advocating for ourselves and finding everyday ways that we can improve the equity and quality of life on our team matters. Stay tuned for more. We'll pick up on everyday work-life balance with occupational balance in our next Alphabet series. I'm committed to breaking these concepts down and illustrating how they relate directly to traditional occupational therapy treatment settings, particularly here in the United States where I practice, but also internationally and across borders. Because I think it's about time that we as occupational therapists and the general public know our distinct foundation so that perhaps we can be more accurately publicly known and perhaps our services more accessible and impactful. And this is part 4 of my OS Alphabet series. We're starting with occupational apartheid. And I recommend going back and checking parts 1, 2, and 3 to get a really holistic orientation to this concept. Really quick, just for context, here is the definition. Systematically enacted negations of humanity that divide and subjugate collectives of people to the benefit of some at the expense of others. This is done through oftentimes intersecting oppressive social mechanisms, e.g. racism, classism, sexism, homophobia, xenophobia, ableism, neoliberal individualism, masterminding unequal access to resources that can sustain dignified living. So one of the reasons why I'm starting the Alphabet series with occupational apartheid is that this is a concept that is commonly left out of entry-level OT. And when it isn't left out, it's often watered down. I made a video about this in, I believe it was part 2, breaking down the different definitions that are included in Willard and Spackman and the 2017 Oxford Dictionary for Occupational Therapy and Occupational Science. And I wanted to offer my perspective in the context of also AOTA's Code of Ethics to illustrate how this need not be controversial, almost at all. So let's take a quick moment to reflect on the absolute roots of occupational therapy, both in the United States and internationally. So starting throughout Europe, the seeds of the occupational therapy profession started a couple hundred years before World War I, by the way, with the moral treatment movement. This is back when we had dungeons, asylums, where those who were considered deviant or defected in society were marginalized, exiled, and treated with cruelty. So the absolute root of occupational therapy is this core idea of moral and ethical treatment of the most marginalized society. Nearly all prior and current professional stances of our regulatory bodies affirm the human rights, which includes in the United States recognizing human beings as being indelible with human rights that are inalienable, right? With this idea of liberty and justice for all, the opportunity to be included, to participate, to pursue happiness, if you will. And in the context of the turn of the century flu pandemic and the of World War I, occupational therapy was also on this premise of returning to life amid the context of war. Kinetic activity, togetherness, and finding a sense of purpose and fulfillment outside of war. What the construct of occupational apartheid, especially when combined with occupational consciousness and collective occupations, invites us to do is to operationalize what it truly means to cultivate a landscape of healing and outside of war, with critical reflections on the structures shaped by our society, which has been shaped by war and marginalization, particularly since the founding of both social relations and governmental developments within Europe and in the United States. It calls us back to our commitments to supporting the most marginalized with moral-rooted ethic, along with broadening our understanding of how wielding of occupation can be a guided path back to life and recovery after the impacts that are destabilizing, traumatizing, and at times dehumanizing aspects of being human and the cost of near endless war. One of the foundational tenets of occupational therapy has been pragmatic idealism, making broad moral reasoning and aspirations and values somehow tangible and implied in our everyday living context, not just in the United States, but all over the world. What's important here is that occupational apartheid, as a distinct within the occupational therapy field, is to start by acknowledging the harms of social marginalization and the impacts of the socio-political and environment on occupational performance, and how our landscapes of social relations, be that through apartheid. In the United States, we have the legacy of slavery, Jim Crow laws, educational environments. If we, as a profession, seek to be in alignment with practical idealism, formation for moral treatment of humans, we have to start with acknowledging the realities, the practical realities of the existence of these systems. This is essential for any professional body that seeks to do something about moral maltreatment of human beings, of the most marginalized, and acknowledging the practical impacts of war and what that causes for human doing, being, becoming, belonging, and what we might do to support affirmation of the humanity of all. This is actually quite a necessary concept in order for us to be both in moral and philosophical integrity as a global profession. What I'm showing you now is AOTA's Vision 2030, the vision statement enriching life for all individuals through meaningful engagement in everyday activities, including enacting an inclusive and equitable professional community, the use of client-centered and innovative practice that are driven by an evidence-based and evidence-informed. If you look at the OTPF, we also can use evidence-informed practice inclusive to diversity of study designs outside of the explicit medical model. We're seeking to be universally recognized, and we have a commitment to occupational justice and advocacy as core tenets to our profession. If we take that a step further to look at the current AOTA 2025 Code of Ethics, we start the whole document with AOTA members are dedicated to fostering inclusion, equity, participation, safety, and well-being for all individuals across these abilities and life circumstances. This is really the foundational commitment that's operationalized through a construct like occupational apartheid. It's acknowledging the barriers that exist to these things being realized. What is so special about the lens of occupational apartheid and occupational consciousness is they invite us to expand our lens of humanity and compassion to include not those on our side of a war, but the collective of humanity who is destabilized by damage to our habitat, to our connection with our human collective brothers and sisters that are often caught up in systems of inequality that have adverse outcomes for our mental health, our spiritual health, our physical health, and our relational well-being as an ecosystem. Whether we're looking at social determinants of health, responses to public health with the relationship of something like a COVID-19 pandemic, and escalating international tensions and violence, which is causing harm on a massive scale, not just to one side or the other, but to the collective of humanity. Occupational apartheid as a lens also helps us to enact our value of equity, of equitable treatment, regardless of where they're positioned within a caste system type dynamic. On top of that, our fourth applied value is justice, this recognition that we should strive to have equitable rights for all and to enact that through actively evolving social systems and our everyday level of consciousness and habits that tend to produce inequitable outcomes and social well-being. Prudence, as operationalized through occupational apartheid and consciousness, imparts on us to actively reflect on the role we may be playing in harmful systems. Our commitment to advocacy empowers our... I'm Dr. Josie Jarvis. I'm an occupational therapist in traditional U.S. practice settings over the past 10 years, an applied occupational science educator, focus of my capstone. If you want to learn more about that, you can check my capstone website, engage.evolvelivingnetwork.com. There you can find a glossary of formal definitions of most of the occupational science concepts that have been incorporated in occupational therapy practice framework and our AOTA WFOT professional commitments. This video is part 5 on our OS Alphabet series focusing at the start on occupational apartheid. For context, I'll just read this real quickly, but I do recommend checking out the other episodes in the series to get a well-rounded introduction to this construct. So this is systematically enacted negations of humanity to divide and subjugate collectives of people to the benefit of some at the expense of others. This is done through oftentimes intersecting oppressive social mechanisms, i.e. racism, classism, sexism, homophobia, xenophobia, ableism, neoliberal individualism, and masterminding on equal access to resources that can sustain dignified living at all. One of the ways that I like to simplify this is actually, I call it like the Scar Reign principle. So if you grew up like me with The Lion King, highly recommend it. But when Scar took over the Pride Lands, he really biased the whole social system in the area, including the ecology, to serve and prioritize his own wins and need, both him and the hyenas. And it really disrupted the ecological balance and the occupational performance and satisfaction of other creatures, right, in the Pride Land. That's a lot of what occupational therapy and occupational science is wanting us to do, is to be mindful to this distinct subjective realities and the functional performance of a diversity of humans in an ecological environmental context, and to seek contexts in which there is inclusion, participation, and healthful thriving of diversity of ways of being in an ecology. This construct in occupational science is really well served when paired with collective occupations and occupational consciousness that have almost co-developed as theoretical lenses. Dr. Awani Ramagundo, Frank Cronenberg's partner, has co-developed and innovated occupational consciousness and collective occupations as a true lens and invitation to engage through the occupational science community. Occupational apartheid itself, along with these others, has rooted from a decolonizing lens of scholarship, and one that has some distinguishing elements from themes in occupational science internationally. So it's okay to look at that one somewhat as a separate village, but all these are different lenses of scientifically informed inquiry. In the last video, we looked at how these constructs actually weave in pretty much smoothly with the AOTA Code of Ethics, and challenging the assumption that these constructs are in and of themselves controversial contributions to the occupational therapy canon. The last video left off on prudence, which is really being mindful to an accurate understanding of the context around you and being diligent in reflecting to make sure that our own biases and kind of blind spots, being mindful to not have those get in the way of our ability to provide ethical, aligned, and powerfully impactful care. Occupational consciousness is very present here. So our next ethical commitment from the American Occupational Therapy Association reads directly as occupational apartheid and occupational consciousness rooted. So here you can tell advocacy is a core value in occupational therapy, actively promoting occupational rights of individuals, groups, and populations, ensuring access to essential resources, services, opportunities for meaningful participation. It includes addressing inequalities by working collaboratively with those who have historically been underserved and remove barriers. Advocacy empowers service recipients to voice their needs and preferences across therapeutic, social, and policy contexts, while also advancing occupational justice through fair and equitable access to activities of daily living. So really, this is really operationalizing the whole of what the concept and lens of occupational consciousness and occupational apartheid are inviting to us as we look through a lens of occupation that transcends clinical and pathological contexts. That's really the magic of occupational science, is the ability to engage with how the form of occupation interacts with daily living internationally without being constrained to only an institutional pathological context. It helps us transcend some of the limits of the medical model and some of the ways that those models disrupt our ability to get a really pure understanding of what occupation is and its potential to be wielded therapeutically. All right, so the next, exploring the relationship between occupational apartheid and occupational consciousness in relationship to the AOTA Code of Ethics Principle of Beneficence, which is basically in our role as occupational therapists seeking to act in a way that is non-harmful and beneficial to our clients. And what happens with occupational apartheid and occupational consciousness, where hegemony, where we grow up in a social context that produce systems inequality and marginalization, that if we don't consciously create awareness of how those patterns are showing up into our everyday life and ways of engaging with the world, that objectively can be harmful and can re-perpetuate systems of marginalization in our daily practice. Things like enforcing fixed gender roles, maybe in our pediatric occupational therapy sessions, where only boys are allowed to color in certain colors, discouraging play and nurturing activities, for example. That's one of the ways where it could show up. Another example, which I'm hoping to make a video on in the next couple, is looking at our disparities in who gets access to occupational therapy and physical therapy in traditional medical systems, especially where the main surgery, the most commonly performed surgery in the United States, a cesarean section, is pretty much the only significant surgical class that's not automatically assumed to be warranted in occupational therapy and physical therapy evaluation. And that is perpetuating a harmful pattern based on our social and cultural belief systems in ways that medical contexts are not designed to be equitable in relationship to surgeries that may be affecting different sexes and genders and can have adverse health outcomes for the collective. If you had somebody who's just given birth, come home not able to safely access a shower, or is in need of an assistive device or counseling on how to care for their incision, that can really have harmful impacts across the board and requires interventions at the systemic level to resolve these inequities. Just a little hint about how engaging in occupational science, occupational apartheid, and consciousness can actually actively create new markets for occupational therapy services. So isn't necessarily even a lens that would lead to occupational therapy somehow being able to decline in our ability to exist as a reimbursable profession. Engaging with these concepts can actually broaden our opportunities and our skill sets to intervene and produce functional outcomes in a variety of different contexts, including somewhat in relationship to capitalism as we seek to also transform harmful elements of those systems. So this is a partner one. Beneficence also partners well with non-malfeasance, which is refraining from actions that cause harm. So if we know that potentially implementing our services in a way that could be racially biased or that could be ableist and exclusive, we want to refrain for perpetuating patterns of service delivery and occupational therapy approaches that could potentially systematically deny rights or override autonomy. And this is where developing that lens and understanding of how these systems intersect with practice settings can be really important to being in alignment with our ethical commitments as a profession. Principle 3, autonomy, is really important. And one of the nuances of occupational apartheid and occupational consciousness where it almost transcends a lot of the academic discourse around the construct of occupational justice, which we'll cover when we get to letter A, is how much it takes into account the inner subjective world that encourages us to reproduce systems of oppressive behavior which fundamentally override bodily and consciousness autonomy. This lens can be incredibly helpful to recognize where some of our subconscious patterning may not be allowing for our clients to have an autonomous engagement with our occupational therapy services. Often when we focus on things like compliance, repatterning some of the very social systems that our OT ancestors were seeking to be a resolution from, such as allowing more autonomy and self-directed liberation in how we're supporting our clients in their own individualized and collectivized patterns of inclusion, participation, and thriving as an occupational being. Welcome to part 6 of the OS alphabet series with the focus on occupational apartheid. In this video, we are hopefully completing the focus on how occupational apartheid connects to the AOTA Code of Ethics, embodying and applying the Code of Ethics in our traditional practice setting. I recommend going back and starting with part 1 to get a really rounded exposure to this construct. If you already know that you want to learn more, I highly recommend subscribing to my Substack, Josie Jarvis OT, where I host the Evolve Living podcast, where I host discussion with interdisciplinary scholars and clinicians and everyday people to help create more public literacy on our distinct science base and foundation of occupational science, so the world has a better chance of understanding what occupational therapy actually is across cultural contexts. And if you subscribe to the Substack, you also get a free copy of the OS 101 guide, which includes an active glossary with formal definitions of all the occupational science concepts that have been incorporated in the AOTA Occupational Therapy Practice Framework, our formal regulations, including ethics documents, and WFOT professional regulations. To help with context, I'll quickly read the formal definition from the primary source on occupational apartheid, brought to us by Frank Cronenberg and Nick Pollard, referencing back to the first edition of Occupational Therapies Without Borders textbook. So occupational apartheid is systematically enacted negations of humanity that divide and subjugate collectives of people to the benefit of some at the expense of others. This is done through oftentimes intersecting oppressive social mechanisms, e.g. racism, classism, sexism, homophobia, xenophobia, ableism, neoliberal individualism, masterminding unequal access to resources that can sustain dignified living for all. Very often, this construct is paired with occupational consciousness and collective occupations, which is contributed to the field of occupational science by Alwani Ramagundo. All three of these constructs come from lineages informed by decolonial traditions of inquiry, which validate the role of narrative inquiry and taking into account internalized subjectivities and how that intersects with power and external social infrastructure, as well as how that can get internalized within our body, mind, and spirit, with the need for support in mindfully deconstructing harmful power relationships. Our previous TikTok left off on autonomy, where we explored how important occupational apartheid, consciousness, and collective occupations can be for respecting cultural autonomy and individual autonomy as a necessary precursor for safety, consent, and cultivating environments of liberation, trauma-informed care, and implementing ethics throughout our practice. Autonomy is central in cultivating environments of mutual liberation and collaboration. So in systems where there is stratified and unequal power divisions based on caste, part of that is systematically endemic to dehumanizing efforts. Those fundamentally have a way of violating autonomy, which is in a core ethic that must be internalized. So occupational consciousness, occupational apartheid, and collective occupations can help developing the skill set to cultivate autonomy affirming care in a cross practice setting. So hugely important. Now we'll take a look at the principle 4 for justice. Occupational therapy personnel shall promote equity, inclusion, and objectivity in the provision of occupational therapy services. The principle of justice relates to fair, equitable, and appropriate treatments of persons that we'd have an attitude of actions of respect, inclusion, and partiality towards persons, groups, and populations in whom they interact, regardless of age, gender identity, sexual orientation, race, religion, origin, socioeconomic status, degree of ability, any other status of attributes, that will respect laws, including human rights laws, right? And civil liberties. So really, in our previous videos, this will really make quite clear how instrumental having that lens in our basic science framework of how to understand occupation by being mindful of how systems impact our ability to access and facilitate occupational justice, ways to create goals and outcomes that are not just mindful to justice-based outcomes, but collective liberation and well-being in an ecological context. Really, occupational apartheid is so fundamental to enacting this principle specifically. Principle 5 is veracity. This relates to occupational therapy personnel providing comprehensive, accurate, and objective information when representing the profession. What's really important here, and where I believe that occupational apartheid combined with consciousness and collective occupations can be really helpful in upholding veracity, especially as a science-based profession, is really our obligation to acknowledge the whole context of the origin of the systems in which we provide services within, the day-to-day realities of navigating. Clearly, the United States context isn't very well set up to support people living with disabilities across the lifespan. Our infrastructure in the United States is, I would say, largely failing to support dignified living for all, especially with the intersection of disability, where often it almost feels effectively illegal to even have your own business to a certain degree because you can be so at risk for bodily harm in going off of health insurance or having those income caps. We have infrastructure that really struggles to make accessible the necessary supports to live and age in place, recognizing the impacts of our mass incarceration system, for example, and how that is impacting mental health, well-being, acts of recidivism. We have a lot of challenges with our mental health infrastructure in the United States in particular, with armed attacks on schools being a very common occurrence and how that can destabilize the experiences and intersections of disability around the access participation. We have extremely restricted laws in many states right now where, for example, there was systematic defunding of SNAP benefits. I've just gotten word in a state in Kansas right now where driver's license have been revoked for gender expansive individuals, limiting their right to access participation, to exercise civil liberties such as voting. Really, this is a necessary precondition through the lens of occupational apartheid if we seek to address barriers to occupational performance, participation, well-being, and perhaps towards liberation. The first start is being comprehensive, accurate, and objective about these systems. Sometimes just going off of how systems are like marketed or how they're advertised might not be the same as the objective realities and the challenges that our clients are navigating in their day-to-day life. So having this lens can help make that visible, help it to be analyzed transparently and with regard to the whole context, both the dark and the light side of occupation. That's another letter that I'm hoping we'll get to cover in the near future. D has a lot of great big words in occupational science. Many people with disabilities speak about how they really want their lives to be humanized, not put on a pedestal or not used for like pity and things like that. We need to have a comprehensive, well-rounded view of how occupational impacts are impacting the everyday lives of people, especially often things come up in occupational therapy that aren't going to come up with any other profession. Fidelity talks about consistency and how we serve and humanize populations, whether it's persons, groups, or populations, that we provide respect, fairness, discretion, and integrity to all. This is so necessary to have occupational apartheid and consciousness be present here, because this is where we can recognize where there are gaps in how people are being treated and where access is being limited inequitably and where we can come together to do something about it. Stay tuned for more. Today we are tying up loose ends, preparing to transition into letter B in the coming weeks ahead, but we are going to talk a little bit about occupational apartheid and its importance, not just to ethical integrity within applied services in the occupational therapy field, which is the focus of our last several videos. Today, we're going to explore on why understanding and applying the lens of occupational apartheid is fundamental to scientific integrity as well. First, we're going to start by getting a primary source definition of occupational apartheid. So direct from Cronenberg, who co-published on this concept with Nick Pollard in the first edition of the OT Without Borders textbook, the formal definition is systematically enacted negations of humanity to divide and subjugate collectives of people to the benefit of some at the expense of others. This is done through oftentimes intersecting oppressive social mechanisms, e.g., racism, classism, sexism, homophobia, xenophobia, ableism, neoliberal individualism, masterminding unequal access to resources that can sustain dignified living for all. The reason for having a lens like this in our understanding of scientific integrity has to do with taking deliberative effort in our objective inquiry, even in a purely deductive format. We have to be aware of built-in socio-political biases that impact what data gets filtered and funded. In scientific inquiry, it's very important that as we engage in that first step of the scientific process of observation, that we are mindful to be inclusive to data sets that are necessarily representative of the phenomena that we're seeking to study and intervene on, particularly in the realm of human pathology. This is a slide from my research partner, Rebecca Seagrave, where we co-presented on trauma-informed maternal health care in rehabilitation settings such as acute care in the 2024 Women's Health Conference. Now, here you can see one of the deficits that not utilizing a lens informed by occupational apartheid has compromised our systemic inquiry and bias as it relates to surgical conditions in the United States healthcare system. As you can see, the number one complex invasive surgery performed in the United States is cesarean section, second to perineal muscle laceration. You can see that the numbers of spinal fusion, hip arthroplasty, and knee replacement really pale in comparison to the occurrence of these very common surgeries in the United States and injury sustained within the context of the US-based medical system. Hip and knee replacements are considered one of the bread and butter diagnoses that rehabilitation professionals address throughout the continuum of care, including acute care, post-acute care, in home health contexts. They're regarded as almost like very lucrative procedures for hospital systems to perform, and it's often considered a gold standard. Joint Center Commission for Centers of Excellence really consider it an advantage for optimal discharge outcomes when knee and hip replacements are given both a PT and OT evaluation with recommendations to prevent hospital readmission. In fact, some of occupational therapy's strongest research is in the acute care context. This study in particular. Now you can see the full title. This study found that spending in acute care occupational therapy was associated with lowering readmission rates more so than almost any other service, with a particular focus on ADL outcomes with alignment with particularly knee and hip replacements, which were really marked and flagged as key diagnoses that we want to try to target for reduced readmission due to the financial consequences to hospitals by not optimizing for ideal discharge outcomes. But knee and hip replacements aren't the only post-surgical outcomes that are currently having a massive impact on our collective in the United States and on the functioning of hospitals. As we just talked about, the number one surgery performed in the United States is actually C-section, as well as post-birth complications with perinatal tears. we have one of the worst maternal fatality crises occurring in the United States compared to other nations, which we can see here break down around intersectional data points. So this is a key sign of not really taking into account aspects of how we're collecting data, biases that are pre-built into the US medical systems that are influenced by occupational apartheid principles, pre-biasing our data and our priorities, which is ending up creating more inefficiencies in the entire hospital. One of the things I really appreciate about Dr. Rebecca Seagrave's research and insight is we were also missing the number one cause of maternal fatality, not actually being of biomechanical origin, but of maternal suicide is the number one cause. And yet we are systematically not only not referring by more biomechanically focused rehabilitation services post-pregnancy, we're also failing to create referral networks for postpartum depression and community-based resources that is leading to the occupation of motherhood, that transition really not being successful to the point of fatality for so many American women. And those that give birth who may not identify with the gender as female. To be in scientific integrity, we need to be as objective as possible in understanding how we are getting our data sets and where we're choosing to focus our funding and our interventions to really be intentionally mindful at what interventions can genuinely reduce risks of hospital readmission for everyone. Unless we're taking into account a really conscious awareness of our socio-political biases that filter into STEM research context, we are failing to implement research and work that can have pragmatic impact and be in scientific integrity. We should not be perpetuating gender, ethnicity bias in how we're conducting our biomechanical scientific questions. And that work must be critically reflected upon and done before the research even takes place. Luckily, using grassroots organizing techniques informed by occupational apartheid and occupational consciousness, I've been able to build coalitions both with physical therapists, occupational therapists, pelvic health therapists, AOTA, and regional leadership to bring visibility to these disparities impacting systemically women of color who are engaged in the birth process and how they're systematically denied access to rehabilitation services such as occupational therapy and physical therapy when sustaining disabling birth complications. This coalition building as an extension of occupation-based and advocacy-focused OT informed by the developments of occupational science was effective in building coalitions and shaping the leadership priorities of former President Allison Stover. In this photo, you can see Dr. Jenna and Rebecca Seagraves meeting Allison Stover and us organizing to respond to pelvic health and maternal care disparities impacting women of color in our shared state of Washington. Fast forward from even just a year after those conversations occurred, we saw Dr. Rebecca Seagraves unite with current president, Dr. Amia Anverizadeh. We also got to bring visibility to this issue with a trauma-informed training for the Women's Health Special Session, which is still virtually available, which has now snowballed into. Now today there are, from this activism, 126 hospitals currently offering inpatient rehab to postpartum mothers to make up for these disparities, addressing barriers to occupational engagement and justice, and securing and creating new markets for reimbursable therapy services. This is the importance of occupational apartheid applied in real life.